Welcome to Dr. Martin, Head and Neck Radiology. In today's video, we will review the radiologic findings of thyroid-associated orbitopathy, also known as thyroid eye disease or Graves' orbitopathy. This condition is the most common cause of adult exophthalmos, and recognizing its key imaging features is essential for radiologists, residents, and all healthcare professionals involved in head and neck imaging. Let us begin with the most typical finding, anterior displacement of the globes. On CT and MRI, the eyes appear pushed forward relative to the orbital rims. This is referred to as ptosis in general terms, but when it occurs in the specific context of thyroid-associated orbitopathy, the more precise term is exophthalmos. Clinically, this displacement explains the striking appearance often seen in affected patients. The second hallmark finding involves the extraocular muscles. They become thickened, usually in a bilateral and symmetric fashion. Importantly, the belly of the muscle is enlarged while the tendinous insertions remain unaffected. This sparing of the tendinous insertion is a key imaging clue that helps distinguish thyroid-associated orbitopathy from other orbital inflammatory diseases. The order in which muscles are typically affected can be remembered with the English mnemonic, I am slow. The I refers to the inferior rectus, M to the medial rectus, S to the superior rectus, L to the lateral rectus, and O to the oblique muscles. In practice, the inferior rectus is most frequently involved, followed by the medial rectus, and less commonly the superior, lateral, and oblique groups. In some patients, crowding of the orbital apex may occur where enlarged muscles and fat compress the optic nerve. This is clinically relevant as optic neuropathy represents one of the most severe complications of thyroid eye disease. In addition to thickening, one may also observe focal areas of lower attenuation on CT. These reflect edema and deposition of glycosaminoglycans during the active inflammatory phase of the disease. Another important radiologic finding is the increase of orbital fat volume. The intraorbital fat becomes prominent, further contributing to ptosis. Imaging also helps in assessing disease activity. On MRI, fat-suppressed T2 or STIR sequences are most useful. In the active phase, extraocular muscles show T2 hyperintensity from edema and glycosaminoglycan deposition. In the chronic phase, they appear iso-intense or hypo-intense, reflecting fibrosis, with reported decreased enhancement due to impaired microcirculation and reduced perfusion. Although the diagnosis of thyroid-associated orbitopathy is primarily clinical, CT and MRI are frequently performed. CT is especially valuable when surgical planning for orbital decompression is required, while MRI is superior for characterizing disease activity and for excluding atypical orbital pathologies that may mimic this condition. Before moving on, I would like to invite you to watch another related video available on this channel, Preseptal Cellulitis, Key Radiology Clues. In that video, we discuss essential imaging findings that help differentiate preseptal from orbital disease. I will leave the link in the comments for you to explore after this lecture. From a pathophysiological standpoint, thyroid-associated orbitopathy occurs due to autoantibodies directed against thyroid-stimulating hormone receptors, which are also expressed in orbital fibroblasts. In the acute phase, cellular infiltration and glycosaminoglycan deposition lead to edema and muscle enlargement. In the chronic phase, fibrosis and fatty infiltration predominate. These underlying mechanisms explain the spectrum of imaging appearances that we see. To summarize, the key radiologic findings of thyroid-associated orbitopathy include exophthalmos, bilateral and symmetric extraocular muscle belly thickening with tendon sparing, increased orbital fat, and in some cases, compression of the optic nerve at the orbital apex. Understanding these features is essential for accurate diagnosis, proper differential consideration, and surgical planning. Thank you for watching this video on Dr. Martin, Head and Neck Radiology. Do not forget to subscribe to the channel, give the video a like, and leave your comments below. Your engagement helps us continue creating educational content for the radiology community.